First of all, thanks so much for joining the California Academy of Family Physicians annual webinar on billing and coding strategies. I'm going to ask everybody on the line to please mute their lines. We are getting some background noise. So if you could just mute your lines unless you have a question, that would be great. My name is Conrad Amenta. I'm the Policy Director at CAFP. And before we get started, I'd just like to take care of a few housekeeping items, and then we'll hand it over to Mary Jean. First of all, you should see on your right-hand corner of your window a little raise hand icon if you have a question. I really do encourage you to enter any questions into the text box that appears, or to raise your hand, or you can break in and ask a question by phone. If we only get a couple of questions, we'll hold them until the end, but if we see a steady stream of questions coming in, we'll pause the presentation and we'll address them. So that's number one. Number two, I just want to make everyone aware that this webinar will not address CMS's quality payment program, specifically the merit-based incentive payment system, or MIPS. That's because MIPS is a complex program. It's complex enough to warrant standalone guidance. So we've created that standalone guidance for you. If you're on this webinar to learn more about MIPS, you can find a very comprehensive guide on our website. If you go to familydocs.org and then click on Practice Resources and Quality Payment Program, you'll find a bunch of resources for you, including a recording of a webinar. So once again, if you're on this webinar to learn more about MIPS and the Quality Payment Program, go to familydocs.org, click on Practice Resources, and then Quality Payment Program, and we'll get a lot of great resources there for you. Thirdly, please know that we're recording this webinar. You should see that we went through the process of trying to turn that on. And so the recording of this webinar will be made available to you afterward, alongside the slides for the presentation, and also we have a written supplement summarizing some of the recommendations you'll hear today. So we'll make that recording available to you. And finally, as a result of attending this webinar, you should know that you're eligible to report CME credits. So as part of that CME requirement, we'll be asking you to complete an evaluation of this webinar. And I strongly encourage you to complete the evaluation when you receive it, as it's really essential for us at the Academy to improve our offerings to you, the members. And then you'll also receive a CME certificate after the webinar is over. So that's our housekeeping. Thanks so much for your patience as we were getting the webinar set up. Thank you, Mary Jean, as well, for all of your patience. And so without further ado, I'd like to introduce you to our guest speaker for today's teleconference, Mary Jean Sage of the Sage Associates, and she's going to take us through some important updates and recommendations for your coding and billing strategies. So with that, Mary Jean, please take it away.
Okay, thank you, Conrad, and thank you everyone for joining us today for this update on what we need to know and be doing for billing and coding for this upcoming year. It is the first of each calendar year that we make those changes. And while some years we have far more changes than we do others, there's always a few things for each of us to take a look at, and then relook at all the resources that we have in our office, as well as the documents and templates that we use, to see if any of those need to be updated as well. So it is that time of year. Hopefully you all have your resources in place. You have purchased a new ICD-10 book back in October when we updated that. You have a new CPT book for this year, and also a HCPCS Level 2 book. They look similar to the books that are on the slide here, even though it's a different year there. So we're going to be talking about coding changes for this upcoming year of 2018, and we're also going to be talking about some Medicare changes for 2018, what we should be seeing from a payment side of things, some new things that we can get paid for now, and a couple of other things that are going on with Medicare that are important for all of us to remember as well. So let's start with CPT. For 2017, we now, the code set itself has over 10,000 codes in it. This is a year when we haven't seen quite as many changes as we have in the past, and that's simply because this code set is becoming very mature now. We've been using it for quite some time, so there are fewer new codes, always some revised codes, and we do take away codes as we find that services are no longer being done, or perhaps they're being done differently, and so we have a new code to replace some of those deleted codes. So from an overall standpoint, we have 170 new codes this year. We have 60 codes that have received some kind of a revision in the description of the code, and then there are 82 deleted codes, and some of those deleted codes include Category 3 emerging technology codes as well. So there are a total of 312 edits in the code set itself, including 2 new modifiers that some of us will be using throughout the year. Here's the general breakdown from an evaluation and management section perspective, which is where we see all of our visits, both inpatient and outpatient. Among other things, we actually have 5 new codes in that section this year. We have 2 deleted codes, and those are the anticoagulation management codes, which were never paid by Medicare anyway because they were always considered bundled. But they've actually been replaced with a couple of new things down in the medicine section that we will talk about a little bit later. In the medicine section, again, because that's where we do have some services as primary care physicians and family physicians, we pick services out of there. We have 13 new codes there this year, and we'll go over some of those in a little more detail throughout the hour here today. Category 3, again, remember those are our emerging technology codes. We have 41 new codes there, but we took away 22 codes, and only one of those 22 codes actually became a full-blown Type 1 or Category 1 CPT code. So here's how we came up with the 170 additions. Also in the appendix, which is where our modifiers are, those the new modifiers there, which are modifier 96 and 97. So as primary care physicians, evaluation and management services are always important to us. We bill a lot of those. So we want to make sure that we are billing everything that we have been doing. And you'll see this year a couple of things that we've typically been doing anyway, we can now get paid for. So remember last year, CMS developed some G codes to report psychiatric collaborative care management. That's that set of services that involve a primary care physician, a team manager of some kind, and a psychiatrist as a consulting physician. So this year, those services are still intact. They are part of CPT, and we do have 3 new CPT codes to report those G codes. We will actually go over the specific codes in detail just shortly. There's also 1 new code for general behavioral health integration services. There are some revision in the observation care services that clearly defines that when a patient is under observation care, they are considered an outpatient at the hospital, not inpatient. So that just means we have to work closely with our hospital to determine what the patient's status is before we bill that. And then anticoagulant management services, again, we deleted 2 codes there, but there are 2 new codes in the medicine section used to report home and outpatient INR monitoring services, because that's actually where most of those services are done now. There are some guideline changes in the evaluation and management service again, and as I just mentioned a minute ago, it does have to do with the observation code description. There is a change from admission to observation status to, it now says outpatient hospital observation status, which just clarifies that the patient must be in an outpatient status rather than inpatient. So they could be an outpatient in the emergency room as far as that goes, or the 24-hour stay unit if your hospital has one of those. But once that patient is deemed to be inpatient, then we need to start reporting the initial hospital care and subsequent hospital care. Another description change that's important for us is in the domiciliary rest home category as well. They have added group home and custodial and intermediate care facilities to that description. It always had assisted living in it before. These are for codes 99324 to 99340. It doesn't really change the description of the service itself. All it changes is it clarifies what you would be reporting as a two-digit place of service code for those. So a fairly subtle change, but one that we do want to be aware of. So here are our new codes for behavioral health and cognitive assessment services. 99492 replaces last year's G code of G0502. That's the initial psychiatric collaborative care management. It is the first 70 minutes on the first calendar month of any kind of care manager activities. So you'll perhaps recall from last year that these are services that involve time spent by a care manager in the activities. They are certainly under the direction of a treating physician who is your billing provider in this case, and it is a primary care physician. It also involves a psychiatric consultant, but that psychiatric consultant doesn't bill for this service. It's our primary care physician that's billing for the service, and while he or she could be providing most of these services, for the most part, it's going to be a care manager that's managing the services itself. So the same type of service for subsequent months, we will use 99493, which is the new CPT code that replaces the G0503 code from last year. So in subsequent months, we report the first 60 minutes, not 70, but 60 minutes of manager activities. The same three professionals have to be involved as they were in the initial service. There is an added element, though, to this service that you have to have this patient listed with a registry where we can keep track of them. And then it also involves the case manager doing a caseload consultation with your psychiatric consultant on a weekly basis. So basically that case manager needs to be at least with a phone call. Doesn't have to be face-to-face consultation, but they need to be reviewing with your psychiatric consultant the patients that you're monitoring and what's going on with them. So just to kind of bring it in more perspective, 99494 again replaces the G0502. That's for each additional 30 minutes on top of either your initial month or your subsequent month activities. And again, remember, we're keeping track of the time of the care management. The 99483 replaces G0505, which is that cognitive impairments assessment. The elements of that service has not changed with the initiation of this CPT code. You must document all elements of that service. And in last year's webinar, as well as in our strategies for coding that we did last year, and there is an update, as Conrad said, coming out very soon, and you'll all get that. We have gone through element by element by element what you need to do there. So refer back to those resources to make sure that you're documenting everything that you need to in order to bill for this. So the 99493 has a typical time of 50 minutes. It's assigned to them on a face-to-face basis, and you should not bill this service with any other E&M services on the same day for that patient. The 99484 replaces HCPCS codes G0507. That's the General Behavioral Health Integration Care Management. Again, remember, care management is performed by clinical staff for the patients with patients who have some kind of a behavioral health condition. So this is just a little bit different than the other services. It is a non-face-to-face service, and we expect that about 20 minutes of typical time is spent in a calendar month, and it's provided by either your physician or non-physician provided, or it can also be provided by staff members under the direction of a physician or non-physician provider. So this service differs from the other in that it can be clinical staff members. It doesn't necessarily have to be a behavioral health team manager that's doing that. And so for that reason, I wanted to just kind of compare those two types of services for you to show you that while you may not be doing everything to qualify for the collaborative care management services, probably most of us with some of our patients are at least doing what we need to do for this general behavioral health integration care management, and that might be a better option for you to be billing if you can't qualify for the other one. So while the 9949 or the 99484 has a little lower payment than the collaborative care management, there are fewer requirements that we need to do for that. And they can also be performed by an existing clinical staff member that you have in your practice rather than a behavioral health manager. But do understand, and this is just an aside here, that CMS hasn't really defined what a behavioral health manager is, but they do use that verbiage and that type of individual in their description of the collaborative care management services. So with the 99484, the general behavioral health integration, a verbal consent is sufficient to start that service. We don't have to have the patient sign anything, but you do need to make sure that you obtain that verbal consent and you document on what day and that the patient said okay to have it. The service does require an initial assessment with the use of some kind of validated rating scales to determine, where the patient is with that. So like the collaborative care management, the behavioral health integration codes, the supervision requirement is general here and not direct. And remember, general supervision means that your physician can be available by telephone. They don't have direct supervision, means they're physically in the office at least, but these are general supervision requirements. So from that perspective, it's a lot. But the bottom line is while you may look at the collaborative care management services and think, boy, these are quite complex and I'm not sure I have all the pieces like the 3 professionals in place to do this, I'm sure many of you are doing the 99484. So take a look at that and consider that you're probably doing some of those services, and maybe have to enhance your documentation just a little bit and make sure that you document all your times in that, but it is a billable service for all of us. So that's our most popular section of CPT where we see for us. Medicine section is, remember, that's the section of CPT that starts with the 90,000 series codes. There are some changes this year that will be important for us as well. So we always get a few new vaccine codes, and we have once a year, once again this year, we have 4 new vaccines that we can report. 2 of them have not yet received full FDA approval, but it is expected sometime around July or so. And so actually the vaccine codes are updated twice a year from a CPT perspective anyway, and they're always posted on the AMA website for that. But the dengue and the zoster vaccine are in the CPT code set this year already. They're there, they're ready. When the vaccine becomes available, you can start using them. So we have 2 new influenza virus vaccines, the 90756 and the 90682, that are available, and you can get that vaccine at this point and start using those. The dengue vaccine and the shingles vaccine are expected to become available sometime later this year, and if and when they do, you have CPT codes for reporting those. Now, we do find that anticoagulant management is generally done by our primary care physicians or maybe our cardiologists as far as that goes. But we do have, with the deletion of those E&M services that were related to these patients, we do have 2 new service codes to report caring for or monitoring the patient that's doing home INR. The first code, the 93792, is used for patients who test their INR at home. So it's patient, and this is to initiate or to educate the patient how to do it. So for the 93792, it is when we do patient or caregiver training for the initiation of how to use the testing equipment itself, and the monitoring. It does need to be under the direction of a physician or other qualified health professional, which are your nurse practitioners or your PAs. It is a face-to-face service. Patient has to come into the office for this. And it does include the use and care of the INR monitor, obtaining the blood sample, which is generally by fingerstick, instructions for reporting the home INR test results, and the documentation of the patient or caregiver's ability to perform testing and reporting services. So when you're doing the training, make sure that when you're done with it, you document that, you know, either the patient or, in the case if they have a caregiver there, that they understood and they could demonstrate that they knew what they were doing and how to do the monitoring. Now, the second new code, the 93793, is for the anticoagulant management for patients taking medication itself, and it must include a review and interpretation of a new either home, office, or lab INR test with results, any patient instructions that you give the patients, dosage adjustment if it's needed. If you don't have to adjust the dosage, you still have talked about it here, and scheduling of any additional tests that need to be performed. So the 93792 is basically one time only, the first time when the patient learns to do this. The 93793 is for the continuing management of the patients that are taking medication and need to learn how to monitor the ups and downs and when to call you as far as that goes. So with the 93792, it is used for those who test at home rather than going to the lab. Prior to starting this, they have to come in and get the education about it. You will note that there are no work RVUs that have been assigned to this service, because most of the time it's not the physician that does this. It's the clinical staff or a case manager. Therefore, no work RVUs have been assigned to this. But it's the 93793, that's the one for patients who are on medication and they're testing at home. Although with this, they can test at home. They could come into the office to be tested, or they could go to the lab to be tested as well. This is the monitoring service itself. So this code does have work RVUs that are assigned to it, because of course our licensed clinician needs to be the one that interprets the test results and makes any dosaging adjustment if needed. You can still bill for this service even if you don't adjust the dose, but you must make sure that there is a new test that's done every time that you bill this service. So the 93792, you would bill once. The 93793, you would bill every time the patient has a new test. Now, it's not every time the patient might have a question and calls into the office about it. A new test result has to be part of the service for billing the 93793. So it doesn't necessarily mean that the patient has to come into the office for this. So you can do this with a phone call, whereas obviously with the 93792, because of the education part of it, you're going to have the patient in the office when you're doing that. So this is what it pays. And you might look at the monitoring code, the 93793, and think, gosh, $12.25, that's not very much reimbursement. Is it really worth it? But the bottom line is you're probably doing it already anyway, because when a patient has a new test, you always talk to the patient about it. That's part of the protocol, that you have them call in for the test results. So it's something you're doing anyway. The reimbursement may not appear to be that much, but now you're getting paid for something that was bundled up before. And there's no limitation on how frequently you can or can't do the 93793. If the patient is having some difficulty and you need to readjust the medication and you need to have them tested again fairly quickly after that, then you bill this service again. There is, at this point, no frequency of service timeframes that have been assigned to them. So from a CPT perspective, CPT in the guidelines for these services themselves tell us to not report the 93793 on the same day as another E&M service. That's the education piece. So if an INR is done on that day of the visit and your physician or other non-physician provider interprets the results, gives the patient the dosage instructions, you wouldn't bill the 93793 in addition to your E&M service. It is bundled with that E&M service and becomes part of that. So also from a CPT perspective, it tells us that you would not report either one of these codes during the service time for chronic care management. Those are monthly services, remember, or transitional care management. So that would be the 30-day period right after someone is discharged from the hospital. They would be considered part of those services as a whole. Another addition in the medicine section is a service for a couple of new codes for ambulatory glucose monitoring. So there's one new code and actually one revised code, and all they do is simply distinguish between who owns the equipment here. So the 95250 is when the physician owns the equipment and provides it to the patient. There is a minimum of 72 hours that the patient must wear the equipment, and you would not report this more than once per month. Now the 95251, which is already an existing code, that's for the analysis, interpretation, and report. And you may report that more than once a month, because if they wear it, have a couple of days off, they wear it again, so you may do this more than once a month. Now the 95249, this is when the patient has their own equipment. They provide the equipment, but you do the sensor placement, the hookup, calibration of the monitor, any patient training that needs to be done, and then help them with a printout of the recording. From, again, a CPT perspective, there is a note that tells us that you do not use any of these codes when you bill a 99091, and you know 99091 is a remote patient monitoring, so that would be a duplication of the service here, and that's basically what the category 30446T code does as well. So it tells us don't bill it with either one of them, but it is considered a standalone service now. So just be careful of the duplication there. So we know that some of our primary care physicians do non-surgical skin lesion treatment in their office. So in the photodynamic therapy section of medicine, we've got some revisions, and we've got a couple of new codes as well that you can use. So the existing code, the 96567, was revised with just a simple parenthetical in parentheses statement to indicate that the use of this code for reporting photodynamic therapy when your physician or your qualified health professional, again, your nurse practitioner, clinical nurse specialist, or PA, when they are not directly involved in the delivery of the therapy service itself. So that's the code you would use when the patient comes in and a medical assistant or another staff member that's been trained to do this would be doing this. However, so now there are 2 new codes that have been added this year, though. The 96573, which reads as photodynamic therapy by external application of light to destroy pre-malignant lesions of the skin and adjacent mucosa with application and illumination or activation of photosensitizing drugs, provided by the physician or qualified health professional. It is a per day code. Doesn't matter how many applications you do, it is a per day code. The 96574 is debridement of premalignant hyperkeratotic lesions using a method such as targeted curettage or abrasion of some kind. That's then followed by the photodynamic therapy and then the application of the light to destroy the lesion. These 2 are per day codes. This service has to be provided by a physician or another qualified health professional in order for it to be billable. So from an actual code perspective, new codes versus revised codes versus codes we don't have anymore, that's all we have for this year. In the evaluation and management services, we're already doing those services. We just code them and bill them directly. And just so you know, for those of you who have been doing collaborative care management, those G codes have been deleted from the HCPCS book this year. So they have gone away. They aren't there. You definitely need to use the CPT codes. So just a little bit about where we're going with CPT in the future, and I think this has to be of interest for our primary care physicians in particular, because there has been this initiative for some time at looking at the role primary care physicians play in healthcare and doing things as a team. So there is a new initiative at CPT that's the Alternative Payment Model Initiative. It goes hand in hand with what's going on with Medicare and our MIPS program that Conrad talked to you about before, and the many resources that CAFP has on their website for you. So this initiative, they've had their first meeting. They are bringing the stakeholders together to get some input about what the coding needs might be for reporting services in an alternative payment model, because again, so much of that is team-based, and there are lots of things like monitoring and communicating and what have you that are not done by our licensed professional. It brings up the point that maybe our existing code set's not really doesn't lend itself to reporting these services very well. So they are actually looking at building an actual APM coding structure. It's not something we'll see probably within this year, because it will take them several years to develop that. And they're just in the beginning stage of hearing from all the stakeholders what the needs might be. So you can anticipate that it'll be a few years before they get that. But it is something that they are working on. And I would say to some of you, if you're participating in some of these models, and we don't have a lot of them west of the Mississippi or here in California, but there are a few, and we are having more and more physicians that are becoming part of them. So if you have an opportunity in your organization to talk about it, or somebody comes to you and would like to have your input on how to best do that, be thinking about what you might suggest and speak up and take part in that. There is also another initiative at CPT called the CORE Initiative, and that's more of an internal initiative. What they're looking at is the whole infrastructure of the CPT mechanism and how it goes about assigning new codes, thinking that they need to update it at this point. making it far more seamless, if you will, and also streamlining the time that it takes to actually get a new code in place. And then thirdly, one of our existing groups, the CPT Telehealth Work Group, has been replaced by the Digital Medicine Payment Advisory Group. It's a new charge to this new group, and there are some new stakeholders in the group itself. It will support the establishment of a clear pathway to clinical integration of digital medicine, which we are seeing more and more use of, in order to ensure the access to high quality and safe clinical care for both our patients and the physicians, and looking at that with always the goal of promoting improved health cares with that. So bottom line is digital medicine is becoming a little more popular. We have new things to look at. So they're getting on board and looking to see, again, what we need from a coding structure to report some of those services and what some of those services will take in mind. So that's, and also just a note, in the practice management newsletter this month, the online newsletter, I think we have a couple of new HCPCS codes that we reported there, and we will cover a couple of them as we talk about Medicare and what's going on with them here. But always remember that not only do we have CPT changes, but we have HCPCS level 2 changes as well. There are some new codes there this year. There are some new J codes, which are injectable medications, although most of those medications need to be delivered via the IV route rather than intramuscular or subcutaneous. There is a new J code there for a new IUD if you do women's health in your practice and do IUD insertion. There's a new J code for that. There's a lot of new G codes, but they are the data reporting codes, not necessarily service codes. There are some new modifiers from a HCPCS standpoint as well. And again, we're going to cover those as we go forward here and talk about what's new with Medicare and what's going on with Medicare this year. But don't always, my point is, don't stop at CPT. Make sure you look at the HCPCS level 2 changes as well. So we have begun a new year for Medicare, which brings about some new payment adjustment. It's not a dramatic adjustment this year. But from a patient's perspective, our Part B deductible remains the same as it was last year, $183 for each Medicare patient. Remember, that's $183 based upon Medicare allowed charges, not necessarily what your fee schedule is. It is perfectly acceptable to start collecting that deductible as the patient incurs charges and services. At this point, one of the things that we are seeing is, while many of our patients do have a secondary insurance that will sometimes pick up deductible and co-insurance that Medicare doesn't pay, that a lot of those secondary insurances are now have a deductible of its own. So you want to make sure that you watch that very carefully. So our conversion factor went up by a lovely 11 cents from last year. The table in the center of the slide here shows you, it illustrates how we got to the 11 cent increase. I have frequently physicians will say to me, well, I thought for the next few years by a MACRA, we were supposed to get a 0.5% increase, and we are through 2019, next year, we are legislatively entitled to an update factor of a 0.5%. But remember, with everything federal, we always have to consider budget neutrality. So there is a downward adjustment of 0.1% with that. And then also in place, we have this, what we call is a target recapture amount. And that has to do with each year we have to look at the misvalued services, and there's a target there. And we didn't quite meet the target. this would be for 2016 actually, because we don't obviously have all the information in for 2017. So that's a 0.09%. So that brings us down just a little bit also. So therefore, we did go up. We just didn't go up very much. So overall, you should be getting about 11 cents more in the being used as a conversion factor. So the bottom line is that some specialties will increase, some specialties will decrease. Within each of your practices, you will see some services that increased and some services that decreased. The decrease could be because perhaps the service code itself was revalued this year, because all codes have to go through once every 5 years to be revalued. It could be because there has been some kind of an adjustment in the gypsies for your particular area as well. So there are lots of reasons why some should go up and some should go down. So a few of the changes for Medicare. Medicare does continue to work with primary care and recognize the importance of care management. So they will continue to pay for the care management, chronic care management, for instance, in cognitive work that has been historically bundled into our evaluation and management code. We started getting paid for that last year. It will continue this year. However, for this year, they have adopted the new CPT codes for reporting several of those care management services. Can we ask whoever, we're getting a lot of background noise. You mute your phones, please?
That's fine.
So we went over this originally a little bit ago, but just to remind you once again, the G0505 is replaced by the 99483, and those are for your cognitive assessment care plan services. Okay, that's the one-time recognizing the patient has a need for the service. The 99492 replaces the G0502, which is our initial psychiatric care management. That's the first calendar month that you do this. You need to get the patient's consent to provide this service. The 99493, which is a subsequent psychiatric care management, that replaces the G0503. So that's the, it is a subsequent month. Now, if you don't spend the typical time, let's say in month 2 after you've done the initiation, then in month 3 you do spend the typical time, then you would still bill the subsequent care management, even though it's month 3 and you didn't really bill anything in month 2. And then lastly, the 99494 replaces the G0504. That's the additional 30 minutes. Doesn't matter if it's the initial or subsequent. You would use that in addition to either the 99492 or the 99493. So again, not new services, but at the end they will be continued to be paid, but just reporting wise, we're going to use different codes. So also at this point this year, Medicare developed 2 codes that would hopefully more accurately reflect the differences in resource costs when additional time is required to provide our Medicare covered preventive services. So the codes are for the first 30 minutes, and then there's a second code for each of 30 minutes after that. So G0513 is prolonged preventive services, and again, you have to always remember this is beyond the typical time of the service for the primary procedure itself. In the office or other outpatient setting requiring direct patient contact. So it has to be face-to-face provider and the patient the first 30 minutes. If it goes beyond that, then we would use the G0514 to report each additional 30 minutes beyond that. But again, the same criteria, it has to be direct patient contact. So these only go on Medicare covered preventive services. They're not going to go on a 99203 or a 99214 or any of those evaluation and management services, it has to be on a Medicare covered preventive service. Just like most of the preventive covered services, the deductible and the copay don't apply to these codes. So what I'm going to do now is I'm just going to bump ahead of, oh, here it is. I did. So on these services, this table here shows you some of the basic preventive medicine services that you would use with these. And then I've given you the threshold of when you would bill the first 30 minutes, then where you need to be in order to bill the first 30 minutes and some additional 30 minutes after that. So our typical IPPE, our Welcome to Medicare visit, the time that's been assigned to that is 30 minutes. So if you're going to do a prolonged service on top of that, you need to do at least 46 minutes. If you're going to do prolonged service more than the initial 30 minutes, then you need to be doing 60 minutes for those. So you see the services that you're going to apply these prolonged preventive services to are nearly all of your Medicare services that start with a G code. Now, there are certainly more than what we have here. You could apply it to any of the testing screening services that we do with Medicare as well. But those are the basic ones, okay? So, and one of the things I think as primary care physicians we don't do enough of is we don't really bill those prolonged service codes when we're entitled to. Some of our patients take a long time. And obviously you have to document the time that you spent and what you did during that time, but don't be afraid to bill for prolonged services. Another change for Medicare this year, and especially for some of our rural practices, they've added some new services to the list of approved telehealth services that Medicare pays for. So they've added the counseling visit to decide or to discuss whether there is the need for lung cancer screening. Psychotherapy for crisis has been added to that list of services, as has interactive complexity psychotherapy. The health risk assessment, the 96160 and the 96161 have been added to that list as well. And then the G0506, which is that care planning for chronic care management services. Make sure that you do use the Medicare G code for this if you bill this. So these have all been added to our list of approved telehealth services. Also, in the final rule for Medicare this year, they have determined that they no longer are going to require using the GT modifier on your claims to report that you met the requirements of the telehealth service itself for Medicare, deciding that that was really redundant because when you use place of service code 02, which is for telehealth, that you're telling them that you have the requirements in place to do that. So do remember with telehealth services, Medicare's requirements are a little more stringent than Medi-Cal or Anthem Blue Cross or some of our other commercial payers as far as that goes. You want to make sure that you do meet their criteria for telehealth before you bill these. So you have to have the patient has to be, you know, the originating site has to be one of their list of approved. You must have interactive system, meaning your voice and facial, and the physician needs to be able to see the patient, and if need be, the patient needs to be able to show them the rash they have on their arm or whatever. So it has to be interactive, and the patient must be present and they must be participating in that service itself. The on the CMS website, there is a document that fully describes all the requirements, and I would suggest that you take a look at that if you're doing a telehealth. The biggest misconception that I always hear from physicians is they misunderstand that a telephone call is not telehealth services. We do have CPT codes for telephone calls, telephone conferences, and while they are not payable by Medicare, but it does mean you can bill the Medicare patient for that because it's not bundled. With some of our other payers, they are actually bundled, but that's a separate service. That's a telephone conference. That's not telehealth. Telehealth means that there's voice and there's facial there. All right, another thing that Medicare will be including for payment this year is remote patient monitoring. That's that code that we talked about a little bit earlier, the 99091, which is collection and interpretation of physiological data. These are such things as your glucose monitoring or your blood pressure monitoring, or some people can even do a type of an EKG at home. So they have changed the status of this code from bundled to unbundled this year, which means that they will make separate payment for that. There is a limit or a minimum time frame that you have to spend doing this, though, which is 30 minutes. So you want to make sure as you're reviewing the data that's probably coming to you through some kind of electronic means or whatever, that you document that you spent 20 minutes or 30 minutes doing that. One of the things you want to be careful of with this new service is don't report it as a telehealth service, even though you may be, receiving some of the data telephonically. It is not considered a telehealth service. So your place of service is going to be 11 most of the time, because that's the office, because that's where you, the provider, are when they are looking at these things. One of the other things that Medicare CMS has recognized this year is the importance of substance abuse treatment, especially with our Medicare patients. So there have been some G codes that have been developed for the insertion removal of implants. And they finalize payment for these G codes as well. So they do describe insertion and removal of it's the naloxone implant, actually, of drug plants to treat opioid addiction. Now, the reason that we have G codes instead of using our existing CPT codes in the 11,000 series that basically report insertion removal and then removal with reinsertion of a non-biodegradable implant, the description of this service is to treat opioid addiction. So the G0516 is for insertion, G0517 is for removal, and the 518 is for removal with reinsertion. Okay. They are, as I said, intended to be distinct from the existing codes themselves because of what they're being used for. And the final rule did finalize some payment for these services, and there was a bit of discussion about it, and finally they upped the payment a little bit, recognizing that the overhead expenses could be substantial for these. So on a national payment basis, and it would be, adjusted to whatever locality your practice is in. But the insertion code pays about $240. The removal code pays a little bit more than $250, and the removal and reinsertion pays about $450. Again, that would be adjusted depending upon what locality you're on. If you are doing these services, remember that there's always always a J code for the implant itself. So in addition to the G code that you're going to bill for the service of implanting or taking it out, you want to, especially on the implant and the reimplant or reinsertion basis, you want to make sure you bill for the J code for the implant itself. Now, a lot of carriers do cover this service as well, and so for those commercial carriers that don't recognize level 2 HCPCS codes, you will bump up and use our 11,000 series, even though it's a more general code description in nature. That would be your option for reporting that. You know, with Medicare, sometimes they'll develop the G codes because the CPT description itself doesn't quite match what they intend to look at or what they intend to pay for. And in this case, that's exactly why we got the G codes. They're tracking when it's being used for opioid addiction to begin with. That's not to say that, you know, sometimes what happens with our G codes is they do go away, as we have a good sense about that with our collaborative care management as far as that goes, and they will replace them with CPT, but you want to continue using these G codes until the time comes, if and when that actually does. So it is a service, it is payable, make sure that you are billing it out. One of the other changes for those of you who do x-rays in your office, whether it's chest x-rays or limb x-rays of some kind, is there is a transition going on from traditional x-ray imaging to digital radiology. We had one change last year. We got another change this year. So again, MACRA mandated that a 7% payment reduction be made to the technical component, only the technical, of x-rays that are taken using computed radiography during years 2018 through 2022. After 2022, there is a 10% reduction. So in order to report this, you're going to apply the FY modifier on claims for the technical component of any x-ray services that you do in your office. Even if you bill globally, you still have to put the FY on. So you don't necessarily have to break your claim down into two lines, one for technical, one for professional. You can still bill globally with one line item, but you would put the FY modifier on that. And you'll recall that payment cuts of 20%, and we had to start using the modifier FX last year when we did film x-rays. So you still have to do that if you're using film, but if you're using computed technology, now you're going to use the FY modifier in addition to that. Another change that has been going on for a while, but it hasn't really been implemented yet. Ordering professionals must adhere to what we call appropriate use criteria when they order advanced diagnostic imaging. So ordering physicians have to adhere to this AU when using a qualified clinical decision support mechanism. Otherwise, payment's going to be denied to the x-ray facility or whatever other radiology facility that is doing the test, or if you happen to be doing them in your office as far as that goes. So it was supposed to start in 2018, but we didn't really, I think, get educated about it and that. So in the final rule for 2018, they did put a delay on the start of the program, and they moved it out 2 years. So the program itself won't start until January of 2020. However, during this year, mid-year 2018, July 1, throughout 2019, CMS is implementing a voluntary reporting period beginning, as I said, the 1st of July for an 18-month period. So you want to take a look at the criteria for doing these, and I've given you a website here, which is actually the Federal Register Final Rule, with the pages where the requirements are listed. Why does that become important to you if you're not a radiologist? So for those of you who've been in the industry for a while, like I have, you'll remember back a number of years ago when we ordered laboratory services, we had to make sure that we had an ICD code that would support the medical necessity of those lab services. Otherwise, the lab wouldn't get paid for the things that you referred over to them. So concept of this is actually very similar to that. So maybe if we're not doing these radiology services, we're not really going to directly be denied anything because we're not billing out those services. Somebody else is going to do that. But they're not going to get paid, therefore, because they need to know that you use this qualified clinical decision support mechanism before you determined that I really needed this advanced diagnostic imaging rather than a straight film, let's say. So we're going to have collaboration between our ordering physicians and our rendering physicians in this case. So I can see that we're going to have, that same type of communication going on between the two groups. So I would suggest to all of you that you take a look at what the requirements are and what these qualified clinical decision support mechanisms are, because you're going to want to make sure that you've documented that in your record when you start to see this. Because after the fact, what will happen is there will probably be some audits done. They'll come back and they'll want to see the medical records, your medical records, for why you ordered these things. So use this time period to become familiar with the program. Whether you decide to, voluntarily take part in the program and somehow let your rendering providers, your outside facilities, if you will, know that you've used this decision-making mechanism, at least become familiar with what they are, what kinds of things you have to consider, what kinds of things that you have to document, so that you'll be ready when the time comes to actually take part and be on board with all of this. So one of the other new things from Medicare this year that are there, and we're all kind of scratching our heads and saying, well, what does this really mean? Is this a new concept? Do I have to do this? Is they have developed some patient relationship categories. Again, MACRA directed CMS to develop these categories to more accurately determine or attribute patients for purposes of holding clinicians responsible for the cost of care in the MIPS, because cost of care is moving into the MIPS program this year at 10%. Of course, your 2020 payment will be based upon that, but cost is starting. And the way one of the elements that is going to be used to look at cost or whatever are these patient relationship categories. So we have 5 modifiers, all beginning with an X, that have been developed to report patient relationship categories. While they're not mandatory that you report them this year, and in fact they won't be used to determine your cost for this year for your payment for 2020, but you can begin using them if you want to. But voluntary reporting, again, won't be a condition of Medicare payment or attributing to the cost. The definitions are fairly general in nature. I think that probably primary care physicians are most often going to be using X1, the continuous broad services. Your other options, X2 is continuous focused service. So the question would be, What's the difference between continuous broad services and continuous focus services? We probably all have a general concept about that, but do we really know? Then X3 is for episodic broad services, X4 is for episodic focus services, and then lastly, X5 is only as ordered by another physician. So what you want to do with these categories for this year, start learning about the categories, what they mean, in what kinds of scenarios would you use one versus the other. If you want to start using them sometime in 2018 and applying them to whatever service you're doing, and most often it would be an E&M service probably for primary care providers of all kinds, you can, and it won't hurt you. It won't be advantageous, nor will it be detrimental to you as far as that goes. So you could start using them if you want to. What I would say, rather than, even if you don't want to start using them, and I'm certainly okay with that, as Medicare is obviously okay with that, you need to start learning about them and what they mean, because at some point they will be mandated, and you do want to use them. That's what you want to use these to support your quality of care, as well as the cost of care that you're providing. So you want to be very familiar with them and use them in an appropriate way. So don't just look at it and say, oh, I don't have to do that this year, so let's not even bother there. Start to get educated about these patient relationship categories and how you are going to best use them for some of the patients that you have in your practices. Another program that's new to Medicare and will start a little bit later this year, but I would anticipate that a lot of our primary care practices could deliver this program fairly efficiently, especially since we already have good results from primary care providers for them doing group visits. And this is really the basis of this diabetes prevention program. A lot of them are group visits. So this is a new program. It was first introduced last year, and providers could start to sign up to be a certified provider if you want to, which is one of the elements of the program. Is you can't just start billing for this. You do have to enroll or apply, if you will, to participate in this program. And you can do that on the CMS website. So you first have to apply to participate. If you're going to be doing it, Medicare will first start reimbursing for it the second quarter of 2018. On April the 1st, 2018, reimbursement is in place, and they will start to do it. So with the final rule this year, so first of all, the program itself is not for the diabetic patient. It's for the pre-diabetic individual, and the prevention program is to hopefully prevent them from becoming type 2 diabetics. So they finalized the components of the program. It told you how many visits the patient could have, basically over a 2-year period. If they're on a weight reduction program, how many visits they can have based upon the success with that weight reduction program, for instance. So they finalized all of the components of the program in the final rule this year. They did establish a maximum payment rate for 2 years of furnishing these educational sessions that, again, are designed to change the behavioral of weight control and ongoing maintenance classes as well. The service itself will only be covered once per lifetime for each Medicare beneficiary. Okay? And again, if you have applied and you are a certified participant for this program, you can begin receiving reimbursement for the program after April 1st of 2018. So this, like perhaps the patient relationship categories, learn about the program, see what's involved. The thing that you will notice with this is a program that can be delivered by a staff member. They have to be qualified from a training standpoint and received the necessary training to do this. But this is a program that is not necessarily physician provided. It goes along with the team concept of providing and care and that. So, and again, I'll remind you, because these are group visits, and a lot of us, especially at CAFP, some of you will remember that diabetic initiative that that you all did a number of years ago, maybe 5 years or so ago, when we looked at group visits, and some of you started doing group visits. That's for our diabetics. Well, these are for our non-diabetic but pre-diabetic individuals here. So you have good results from group visits. So I think it would probably be a little easier for you to implement this program than some of our other physicians as far as that goes. So a couple of last things for Medicare before we wrap it up today. Medicare did retroactively go back and adjust a couple of their old programs to kind of bring them more in line with our new value-based program and incentives that they have. So they retroactively lowered the PQRS and meaningful use reporting requirements and reduced the size and scope of our 2018 penalties under the value-based payment modifier. So that's the only adjustment that we should have at this point, although they were tied to the other two programs. So it was done, as I mentioned, to align our past programs with the new requirements with MIPS that we have at this point. So what it means to you as a practice, and this would only be if you are getting an adjustment of some kind, for practices that fell short of our PQRS criteria, remember the automatic value-based modifier penalty was 4%, but they have decreased that down to 2% for groups of 10 or more, or from 2% down to 1% for our groups of 9 or less, being our solo individuals. So if you're a solo practice, you shouldn't be getting any more than a 1% reduction at this time. If you're a larger group, and we don't have that many of our larger groups that weren't participating, but there are still some there, your adjustment should be no more than 2%. So the bottom line is it will probably reduce a fewer or at least less significant payment increases to our higher scoring groups, and it will instead do the same thing to our solo practitioners if we have those that are high scoring as far as that goes. So it's all in the penalty and bonus, because remember, with our new programs, we're paying our bonuses from the money that we save from those who haven't participated and are getting an adjustment. So if there are fewer of physician groups getting adjustments, then there's obviously less money to pay out from a bonus standpoint. So some of you, when you look at your fee schedule, remember way back there I said some will increase, some will decrease. Some of you may actually see that your overall reimbursement increases a little bit, because if you were suffering from a penalty, that penalty is going to be smaller at this point. Then lastly,
Mary Jean, this is Conrad. Can I just break in for a moment? Sorry, we're getting a lot of background noise. I just like everyone on the line, if anybody hasn't muted their line, there's a phone icon on the bottom left-hand side of your screen. It says mute. If you could just click that or mute your phone. We're getting a lot of background noise on the recording. It's making it a little bit difficult to hear Mary Jean speak. So if you could just mute your lines until the end of the call, that would be great. Thanks, Mary Jean.
Okay, sure. And we are almost finished as far as that goes, but yes, that will help us a great deal. So lastly, I wanted to just let you know and talk a little bit about our evaluation and management documentation guidelines, because remember, our evaluation and management codes are developed by the AMA through the CPT process. But the documentation guidelines that Medicare uses to review some of our E&M services were developed by CMS in conjunction at one point with a lot of other stakeholders as far as that goes. Well, it has been brought to the attention of CMS probably for a number of years now, but they are sitting up and looking at it now, that the documentation guidelines from both 1995 and 1997 may be outdated. And for those of you who went through that process before, you'll recall that we got the 1995 guidelines, and then it didn't really fit a lot of the physicians, and there was a lot of outcry about that. So in 1997, they tried to redo those guidelines, and they did come back to our physician stakeholder groups and ask for their input at that point, which they hadn't with the 1995 as far as that goes. And so from that point on, from 1997 on, we've been able to use either the 1995 or the 1997 guidelines based upon your individual preference, or if you were in a larger organization and they told you to use 97 versus 95, for instance, you would do it because of that. But from Medicare's perspective, you could use either one of those. Well, they have started the process to relook at these documentation guidelines. They're in the process of bringing everybody together, if you will, to talk about what's awful about them, what needs to be changed about them, how we can best change them, especially with the advent of so many electronic health records. So it is a collaboration with all kinds of stakeholders. It is very obviously a multi-year project. It's going to be a while if it is ever resolved. But you want to be aware that they are looking at them. And if you're asked to participate through your local medical association, your professional association like CAFP or AAFP, you want to get involved and make your likes and dislikes, if you will, known. At the annual CPT Medicare meeting in Chicago in November, the CMS representative opened up the floor for discussion on this. And this is a big meeting. There's like 1,000 people at this meeting. But I will say that I was impressed, and she did a great job of controlling it, and the attendees did a great job of stepping up to the microphone, saying, you know, from their perspective, what the problem was, what they needed to think about. And she took down every single suggestion or every single comment that was made. Now we'll have to wait and see how that comes into this collaboration, if you will. But they're not changing immediately, but it is in the works. They are relooking at these. In the final rule itself, there were a number of comments, and they had addressed some of those comments. They are continuing to garner more comments about what we like, what we don't like, what's working, what's not working in that. So if you're asked to participate, participate. Don't hesitate to do that. One last thing about Medicare. We're all going to deal with this at some point this year. Our Medicare patients are getting new Medicare cards. Along with them come a new Medicare number for all of them. The card in the forefront of the slide here is what the new card will look like. It will still be red, white, blue, just a little different arrangement, if you will. The new card does not affect coverage for the Medicare patient. They will maintain their original effective dates for both Part A and Part B, whatever that was. From your perspective, a couple of things that you need to be aware of. The Social Security numbers, as mandated by law, have to come off of the cards by April of 2019. So while the cards in the past have been Social Security based, and we call it a health insurance claim number, which never made a whole lot of sense to me, but anyway, that's what it's called. They're being replaced with the Medicare Beneficiary Identifier, and MBI is the new acronym. They are 11 characters in length. They're numbers and uppercase letters, no special characters like hyphens any longer. Each of the numbers is unique, and it's randomly generated by a computer, actually. And the characters are what we call non-intelligent, which simply means that there's no hidden meaning or special meaning to any of them. So, you know, we all knew before that it was the Social Security number, and then depending upon the alpha character after that, the A, B, T, or whatever, that had special meaning for us. These numbers will have no special meaning to them. Okay. The new number itself, again, let me stress, it won't change their Medicare benefits at all. People who have Medicare, as soon as they get their new cards, they can start using them. The effective dates, again, like their old cards, will be the date of each beneficiary, whenever they became eligible for Medicare. So you'll have effective dates that go back years and years and years. That part is not going to change. But it does mean a change for all of us in our offices, because we're going to have to change some of our systems that we have in place. So we'll start to mail out the new cards in April of 2018, a couple months from now. They're going to mail them out by geographic location, and I'm not sure exactly what that means, whether they'll do states at a time or if they'll break them down, you know, even more. So the good thing about that is you probably won't have patients getting new cards throughout this whole next year or so. When they start to get the new cards, basically all of our patients should probably be getting their cards about the same time. Okay. Now, there's not going to be any kind of testing done with the systems to make sure that these new cards work. So because there isn't any end-to-end testing, you can use either your HICN, your health insurance claim, or the new Medicare to submit your claims during the transition period that we have. The systems at Medicare at our contractors are supposed to be set up to take either one of those. The transition period itself is an 18-month period. Even though the cards are going to be mailed out between April 1 of 2018 through the end of March of 2019, they don't actually, it's not mandated that they start using them until 2020. So your transition period is a full 18 months, 1st of April 2019 through the end of December 2019. But come January 1, 2020, we need to start using these new MBI cards. So, and there are a few exceptions to using the HICN number, the old number versus the new numbers. None of those are claims-based. Definitely at the end of the transition period, you're going to have to use the MBIs. But some of the things like your appeals process and some of those things, you can either use either one of those when you go through those. But to submit the claim itself, beginning in 2020, you need to have those. So you need to start getting your systems in place to start entering those new things in place and what have you. So there is actually a little tear-off pamphlet, it's just a one-sheet thing that you could get free of charge from CMS to have in your office to hand to your patients, just to let them know that they're going to be getting a new card, and they should actually, what the pamphlet does is it gives them a couple of things that they need to do to make sure that they get their new card when they're supposed to. For instance, one of the things it tells them to do is to go online at the Medicare website and make sure that their address is correct, and so that they can receive those cards. So you can check the new Medicare card payers and employers page for resources you can use to not only talk to people about Medicare, about the new cards, but there's a link there where you can get the technical specifications for your computer systems to make sure that your formatting is done correctly. Now, to some degree, our software vendors will probably have everything in place and be willing to help us with that, but you don't necessarily want to depend upon them until the last minute to do those. So number one, also, some of us will have patients who become eligible for Medicare, newly eligible, if you will, after the 1st of April of this year. So they're not going to have an HICN number. They're going to have an MBI number instead. So you're going to have your computer set up ready to accept these numbers fairly quickly after the initial issuance of some of these tests. And since they're the same number of characters, if you will, there probably won't be that many issues. But, you know, every single one of our systems are a little bit different, so don't be caught short. Make sure you get everything in place that you need to in order to do that. So lastly, and here's the webpage at CAFP for your resources for MIPS. MIPS is definitely Medicare related. There are some changes for MIPS for this year. Don't wait until the last minute to see what those changes are. One of the most dramatic changes is obviously that the Pick Your Pace program went away. And so you don't have the option of submitting one measure one time for one patient in order to exempt yourself from a reduction or an adjustment. So make sure you're on board with MIPS and know what it is that you should be doing and need to be doing at this point. Use those. The resources are wonderful at CAFP. Make sure that you use them. As Conrad said, it's a much more complex program. You need to make sure that you're on board with it. Also, just a note that is if you haven't reported for 2017 yet, the deadline is coming up. It's the 31st of March of this year to get your report in for last year, so don't miss that deadline as well. And with that, we have used up all of our time, but I want to take some time for questions. So do we have questions that have come in, Conrad?
Thanks so much, Mary Jean. Just a quick reminder to everyone on the call, if you have a question for Mary Jean, there's a couple of ways you can submit it. You can either unmute your line by clicking the little phone icon in your bottom left-hand corner of your window, or there's a text box that you can enter some questions in. And we have received a couple of questions over the course of the webinar. Okay. Let's go through each of them one by one just to make sure that they've each been answered completely. The first one is with regards to code 99483. And the question was, and I think you might have answered this, Mary Jean, but let's just go over it just to make sure. How does the 99483 differ from the cognitive assessment in the annual wellness visit?
Well, it is, it's a little more comprehensive than that. It also could be done at a different time. So you would not do the annual wellness visit and bill for that cognitive assessment on the same day, because those would likely be bundled. But let's say you do the annual wellness visit on the patient, and then a couple months later or whatever, you find the need to do the cognitive assessment. So it would be a separate service. So, and as I say, the elements of that are a little more comprehensive than what you do in the and what you would do in the annual wellness visit. But don't bill both of those on the same day. Make them two separate services.
Great, thanks, Mary Jean. The second question we have, and to all participants, if you have follow-up questions about what we're asking, please feel free to enter them in the text box or to ask them over the phone. The second question we have is with regards to code 95250. And the question was, what do you mean about the minimum of 72 hours?
They have
That's for 95250.
Okay, so they need to be wearing the monitor for a minimum of 72 hours.
Okay. The next question we have, actually I have a general question here. If any of our participants have a number of questions, Mary Jean, would it be best, would you be open to receiving those questions by email? And you might be able to answer them that way if our attendees have quite a few.
Absolutely, I would encourage them to do that. And what we will do is, if the questions or the answers would be important for everyone, then Conrad or somebody at CAFP will email the answers out to all of you after the fact. So if you want to email me directly, I always share those with CAFP, and then they can make it available to all of you.
Great, thanks, Mary Jean. So for those on the line, if you have a longer set of questions than you feel comfortable asking here, you can email them to Mary Jean, excuse me, at mjsage@thesageassociates.com, mjsage@thesageassociates.com, or you can always email me. It's camenta, CAMENTA @familydocs.org, and I can make sure that everybody sees them. The next question we have is a question asking for 1 or 2 examples of what would qualify for prolonged preventative services.
All right, so that's probably something that I can document out for you and make available to all of you, but just in the short term, let me just go over a couple of things. So, you know, if in the course of doing those services, maybe let's say the patient has a very prolonged history, and so it's taking you a long time to take the history, or for instance, the annual wellness visit. You know, part of the annual wellness visit is you do that 5-year plan or whatever for all the preventive services and make sure that they get their mammogram when they're supposed to, and that they know that they should get a flu shot and all of that. If it takes you a very long time to go over their plan of care with them, and you go beyond that threshold that's assigned for the typical time, then that would be a time when you would do prolonged services. Now, you also remember that with the annual wellness visit, it's voluntary, but you can do advanced care planning at the time of the annual wellness visit if you want to as well. So in the instance that you're doing advanced care planning and that element of it takes a very long time, then that would be a prolonged service as well. And you want to be a little cognizant of your appointment schedule too. In this particular instance, if it's taking, you know, a long time to do that, you might want to have the patient do a second appointment for advanced care planning, because that is a separate service in and of itself. You just, it's when you do it at the same time as the annual wellness visit, some of the payers take a look at that, because it, you know, we had that whole issue way back. Was it going to be part of the annual wellness visit, or was it going to be, what did Sarah Palin call it, a deaf panel or something like that? And so it became a voluntary and optional element versus the other. So be a little careful about billing those two things at the same time. But if you are doing that, and let's say you're spending a lot of time on advanced care planning because you couldn't bill that as a separate service, then that could be a prolonged, that could qualify for prolonged service. But any one of those elements that takes you an especially long time, why that would be used to prolong. And coordinating care is part of that service also. Sometimes that can take a very long time.
Great, thank you for that.
I mean, but I'd be happy to actually document out a couple of things, and that we could share that with everybody. Or you know what, Conrad, how about if we, in an upcoming practice management news articles, we address that issue with some examples? We could do it.
I think that's a great idea. All of the questions that we receive by email following this webinar, we'll document them and send them out to the attendees, and we can include some of those examples in that, and then we can also make this the subject of a future practice management news.
Okay.
So we're just coming up on the end of our allocated time here. We're running about 10 minutes past the scheduled time because of our technical difficulties at the beginning, but I just wanted to provide another opportunity if anybody on the line wants to ask Mary Jean a question while you've got her here. You can unmute your line and ask the question, or you can type the question into the text box on your window. just give it a couple of seconds here. Just to remind everybody that we have been recording this webinar, and we're going to make it available to everybody after the fact alongside a written supplement that will outline some of the biggest changes. And that following this, the end of the webinar, we're also going to be emailing each of you with an evaluation. Really, please do fill out that evaluation. We read them really closely. We use your feedback to improve our offerings to you. And then also we'll be sending you a CME certificate. So not seeing any additional questions, I just want to take a moment here to really thank you, Mary Jean. There's a lot of really amazing information in here, and really put you on the spot with some of those questions, and really appreciate you taking the time today.
My pleasure.
So thanks to you. Thanks to everyone who took the time to phone in, and watch out for the recording. And we'll come back next year for another great update. Thanks, everybody.